Well, good afternoon, everyone, and welcome to the latest installment of our Learn at Lunch series. I really appreciate Heidi Williams from Orthopedic Institute helping to arrange this presentation. Today we have Dr. Jonathon Geisinger from the Orthopedic Institute. He is going to give us a presentation on cervical myelopathy, and I think Dr. Geisinger, I'll let you take it away and let you do an introduction and get started on the topic.
Yeah, well, thank you so much. No, thanks for asking me to do this. It's very nice of you guys. I'm happy to do it, and I'd be happy to do more in the future as well if you guys have topics that, especially stuff that you guys want me to go further, deeper on anything that you're questioning or anything. I can sure look at that again in the future, another session. But so this talk is on cervical myelopathy, the pathology, the diagnosis, and also the treatment of it. I did send out some packets. I'm fairly new to the area here. I've been here for the last 2 to 3 months, and I did send out some packets to the chiropractors in South Dakota. So maybe you guys got those in the mail or not. I'm not sure. But if you haven't got it yet, look for it. It should be coming.
Could you remind us where you're practicing at, where your satellite clinics are?
Sure. I'm at Orthopedic Institute in Sioux Falls, South Dakota. And I'm in clinic every Wednesday and Friday here. And then Mondays I go to Brookings. And every Monday I'm in Brookings doing clinic.
And then your specialty is spine?
Yep. Spine is the thing that I focus on. Cervical, thoracic, lumbar. Pretty much anything that's spine is my forte. But, we're trained in orthopedics, and I do a little bit of everything as well. So if you needed help with guidance of a patient through the system, I'm happy to help in any way for pretty much anything, really. But spine is my fellowship, yep. And if you guys have any questions like that, just please speak up throughout the presentation. Just interrupt me with whatever you need. I'll give you a little bit of background about myself. I'm originally from Spencer, Iowa, is where I grew up. My folks farm there, and I grew up farming. And my wife is from the same area, and her family farms as well. That's a picture from me probably in high school, and I was working on the field cultivator. And the Clay County Fair, that's probably the most known thing for Spencer, Iowa. It's just a wonderful fair we have every September. So if you guys ever get a chance, I mean, it's spectacular. It's an awesome fair. From there, I went to the University of Iowa. I did 4 years there in undergraduate training and got a major in integrative physiology. And then from there, I went to medical school right there at the University of Iowa at the Carver College of Medicine. So 8 years I was in Iowa City. Following that, I went out to Royal Oak, Michigan for residency, which was just north of Detroit. You tell your folks and everybody we're going to go out to the Detroit area, and everybody's just terrified of that notion. But Royal Oak was a beautiful setting. It's nice suburb, very safe out there, and just a huge hospital. This hospital had 1,300 beds in it, and we had 30 orthopedic operating rooms, and we were just very, very busy. That's the group of guys that I trained with in the top right there. And from there, I went to Twin City Spine, and I did a spine fellowship. So that's one more additional year of training so you can be subspecialized in spine related pathology. And Twin City Spine is a very, very large and historic program. It's the oldest fellowship in America, and they've been treating spinal conditions there for just decades and decades. So great guys up there, and I was happy to learn from them. And this is the group of guys that was in my fellowship. To give you a scope of the size of this place is typically a place will have one fellowship or one individual each year for their fellowship, and they have such a high volume up there that they had 5 fellows. So extraordinary place. And that's a picture of a very complicated patient we took care of, and it just shows you the degree of the real severe conditions that come to us up there that we took care of. So following that, my wife and my kids there, we settled in Sioux Falls, South Dakota here. Very happy to be just 2 hours from home. That's just been great, getting home and combining on the weekends and seeing our grandparents a lot more. So the kids are happy, and we're just very enthused to be here. So that's kind of a background on me. Now we can get to what you came here for. I was going to talk about cervical myelopathy today, and maybe you guys are probably already familiar with it, but it can be kind of a tough thing to pick up clinically to really know what you're dealing with, unless you're kind of cognizant and thinking about it and always have it somewhere in the fore aspect of your mind. So basically what cervical myelopathy is it's when you have a very severe tightness on the spinal cord. And you can see on this MRI, it's C3 and C4. You notice C3 is subluxed posteriorly on C4, and that creates, and this is also degeneration of a disc, and those two things can compound each other to cause severe tightness on the spinal cord. This is cerebral spinal fluid. This is the white stuff here coming down, and you can see in front and behind the cord, that's what you want to see. You want to see that spinal fluid. Here, there's no spinal fluid. In fact, it's pinching the cord in, and the cord is actually starting to die. And I think you can appreciate, at least on my screen, this is called cord signal, the white area within the cord right there. And what that means is the cord is actually undergoing a process called demyelination. So all of the nerves, or most of the nerves in your body, have insulation on them called myelin that allows for the conduction of electrical currents and things through your nerves at a faster rate. And when you get this much tightness on the cord, the cells that create that insulation on the nerves, they start to die. They're very sensitive to pressure. And when they die, you lose the insulation then, of course, but then you also undergo a scarring. And with the scarring comes an inflammatory process as these cells are dying. And so you get inflammation and swelling and what we call edema in the cord. And so it's that edema, or the inflammation, is what we see in the cord right there. And so all of those things we know are going on, and it's leading to a very poor outcome for this person unless there was a type of intervention that we can offer them, and luckily there is. So this is a patient I took care of, one of the first patients that I saw here, and she's had a previous 2-level fusion done 20 years ago and did well from it, but she came in just complaining of some numbness in her hands, and the numbness was starting to get worse. It was starting to go up the back part of her forearms on both sides, and yeah, so she thought, oh, I'll just go in and maybe get this checked out, and just kind of starting to get a little bit concerned about the numbness. But I started talking to her, and that's why you really got to talk to these people, and through this talk you'll kind of learn how you tease out these things. So I started asking her about, well, how is the use of your hands? Do you feel like you're clumsy and stuff like that? And she goes, yeah, I do feel like I've been getting clumsy over the last couple of years, and especially the last year. And then you ask, are you dropping stuff? And oftentimes they'll be like, yeah, I am dropping stuff more often now that you mention it. And really a key one is walking. They will start having issues where they just, especially on uneven ground, they'll just find that they're always staring at the grass, or they're staring at the ground to make sure that they're not going to fall over. And that's because the signal, the proprioception, or the sensation of where your body's at in space, isn't getting up to the brain because you have a sick cord that's very tight, and it's not giving that information to the brain. So the brain has to compensate by using its eyes to get that sensory information to know where the ground is and things like that. So oftentimes you'll just say, hey, when you're walking on grass, are you staring at it more? And they'll be like, oh yeah, I'm staring at the grass a lot more when I'm walking. These are all subtle things that people just think are old age and things that are coming on. Oftentimes they won't have any weakness. You can get weakness with it, but not always. And typically pain isn't a big thing. This lady really didn't have a lot of neck pain, but they do get neck stiffness. They'll tell you, I have decreased range of motion with my neck, and it's pretty stiff. Yeah. So physical exam-wise,
so just before you move on from the history, did she present to you as you were the initial consult, or was she being treated before she saw you or anything?
Nope, she was the initial consult. She's seen another guy here, I don't know if it was a knee or a hip, and kind of followed along, and then she just decided, I'm getting this numbness in my hands, I'm just going to go talk to this spine guy about it. So it was kind of a fluke thing that she ends up in my clinic. So So physical exam wise, she had great strength in the uppers and the lower extremities. She did have numbness in her hands, and it was starting to go up the back part of her forearms. And she had a lot of hyperreflexia in the upper and the lower extremities. And she had a positive Hoffman reflex. And you're probably familiar with that. But that's a type of reflex where it's a pathological thing where you flick this fingernail, and you'll see people that are pathologic will do this. And that's called a Hoffman. So you'd flick it, and they'd go like that. Not quite as dramatic as I'm doing, but that's a sign. It's a primitive reflex is what it is. And when your cord is sick and the signal from your brain is no longer getting to the cord as well, your spinal cord starts taking over these primitive reflexes. And so that's a primitive reflex that we know, and a sign that you have tightness on your cord. And then also the gait. Gait's an easy one to have them do. Do a 1 foot in front of the other, a heel toe kind of walk, like a drunk walk, like a cop would have you do. And if they can't do that and they're falling over, you know, that's a good sign that they're having issues related to their spine and coordination. This is her MRI, and this is an image that cuts in half from the nose back. And this part is the front, this part is the back. Again, the spinal cord is here with spinal fluid in front and behind. And you can see right here the white area where her cord is dying. She has a large, I can see it well on my screen, hopefully you can as well, but she has a large area where it's very tight on her cord that's causing significant tightness. And she has a lot of tightness all the way from the bottom of C3, you know, to C6. So she had multiple things. She has what's called congenital stenosis, which means she was just born with a small spinal cord. And then she had a lot of degenerative processes that have led her to have even tighter space for her cord. So we'll get back into the talk a little bit, and we'll find out how she does towards the end of the talk. Just briefly, we'll kind of go over the causes of myelopathy, like how do you get this? So the first thing is a lot of people that have it are just developmentally, they're just born with a small spinal canal. Some people are just genetically gifted to have a large open spinal canal, and some people just have short spinal canals, and so that sets you up to have this sort of disease process. You can have degeneration, both if your disc starts to bulge out or it gets degenerated and starts to push into your cord, that can cause it. Ossification of the posterior longitudinal ligament, which is shown in this CT scan right here. This being the front, this being the back, and the spine obviously coming down here. You'll notice that there's this long, slender piece of bone formation on the back side of the vertebra right here. And that is ossification of the posterior longitudinal ligament. Normally there's a ligament here that connects the vertebra together, but in some people it undergoes calcification, and once it does that, it pushes on the spinal cord. And that's actually more common in Japanese population, and they don't know why, but maybe it's from all the sushi or nitrates is kind of the speculation, but that's very common in the Japanese population to see. So you can also get arthritic changes at the facet joints or the uncovertebral joints, or which are the joints right between each one of the cervical vertebra, and those big osteophytes can push out into the cord. And then just with age, sometimes the ligamentum flavum, which is a ligament in the back of the spine, gets hypertrophied and grows in and buckles into the cord. And usually it's a combination of several of these mechanisms that give you that severe tightness on the cord. And then also there's dynamic reasons for it. So if the spine is slipping forward or backwards and you have an unstable level, like you can appreciate this level is slid back as compared to this level. And if that's dynamic, somebody could go into extension and bring their bone back into the spinal cord and then go into flexion where it reduces and comes off the spinal cord. So there's a lot of different reasons to have it. Things you look for in terms of clinical symptoms of myelopathy. So one, the gait instability, which I've already kind of addressed, feeling like they can't walk on uneven ground very well. Useless hand. They get a lot of clumsiness in their hands and they just don't feel like it's their own hand. Penmanship, that's a great one to ask. I ask a lot of people that. I say, in the last year, have you had more difficulty writing? Has your penmanship gotten worse? Thenar and hypothenar atrophy. This is kind of a late finding, but this is the thenar group of muscles right here, and you can see they're very atrophied. and then the hypothene are over here, which are also atrophied on the picture. People do get weakness with it occasionally, and that'll be more weakness up in the deltoids or the hip flexors, and then hyperreactive reflexes. Again, the brain is no longer communicating well to the limbs, and so the spine starts taking over. And when the spine takes over its own reflexes, they're a lot more reflexive than when the brain is giving control over it. And then the pathological reflexes we talked about, like the Hoffman's, there's a brachioradial reflex, there's Babinski sign, all of these other reflexes that you can do to key in on what's going on. So this is important to know, is the natural history of it, because without the natural history of knowing how disease processes progress or change, it's pointless, right? So we got to know what's going to happen to these people if we intervene or don't intervene. So Clark and Robinson did a study back in 1956. They had 120 patients that had this, and basically this is kind of the Cadillac study that showed that 75% of these people are going to get a stepwise deterioration of their function. And what that means is they'll do well for a period of time, and they'll be like, oh, my hand is clumsy, or I'm dropping stuff, and they'll level off. And that could be a week, it could be a month, it could be a year. We don't know how long they level off for. But then it's going to be followed by a very abrupt decrease in their function. So they'll be dropping objects, and they'll be fine, and then all of a sudden it'll get way worse, and they will have a lot of clumsiness of their hands, or they'll be falling over more. And then they'll stabilize again for a period of time, and they'll have all the same symptoms, followed by another stepwise decline, where it's an abrupt decrease in their function. And so that's really the natural history of this cervical myelopathy. Lees and Turner also had another study in which validated the stepwise deterioration in their neurologic function. So 14 of 15 that had severe myelopathy in their study continued to be disabled at 20 years, meaning that people that have cervical myelopathy really don't get better. They just continue to get worse and worse and worse, and they stay disabled. Nurek, he has the Nurek grading scale, which is fairly well known. Basically, from his study, he had 36 patients that were treated non-operatively, and he basically just tried to correlate who got worse and how they got worse. And what he found out was people that presented with more severe symptoms and were older tended to get worse faster. So if people come in with bad symptoms or they're elderly, those are the ones that are probably going to have a shorter stair step in their decline. CSRS, Cervical Spine Research Society. This is a very prestigious research society, probably our best cervical research society that we have in America and really in the world. It's not sponsored by industry for the most part, and all their studies come from grants. And so really this is, when you see studies from this society, you know that they're done very, very thoughtfully. So they did a multi-center non-randomized study of 43 people that had myelopathy. The 23 people that had surgery, they improved their neurologic symptoms. They had better pain and better function. The 20 people in that study that did not have surgery had worsening neurologic function and more disability. And so from their study, it supported that poor outcome with non-operative treatment, meaning that when people have these severe symptoms, it's not typically something that you would manage non-operatively. Conservative management, there is a role for it, though. You can do anti-inflammatory meds. You can try some physical therapy, isometric type exercises with that. You could try a steroid injection. And then also orthosis. You could give them a cervical collar, and that can decrease the symptoms that they're having in terms of their nerve root symptoms for a period of time. And really the key is, if you are going to watch these and we're not going to do something about it, I always tell these people we're going to see them back in 3 to 6 months. And I'm going to get another exam, and we're going to have another visit. Because the thing is, if it does progress, you want to catch it before it gets too severe. Okay, so if people want to watch it, that's fine, but you got to be careful and you got to follow them closely. And then if they're having severe symptoms, they're usually not going to get better. The indications for surgery is how long have they had the symptoms, how bad is their spinal cord dysfunction, how bad is their functional status, what do their x-rays look like, and in general, how is the patient's health. Duration of symptoms. neurologic recovery really depends on the preoperative duration of symptoms and also the severity. So if people had these symptoms for several years, they're not going to have a great outcome. What this is saying is when you identify this pathology, you need to treat it sooner than later, or at least give it, you need to stabilize it so it doesn't get any worse. And then less than 1 year of symptoms, people typically have a better recovery. So when we operate on this, we tell people, every single person I say, we're doing this to stabilize your function. I can't guarantee you're going to get better, but we're doing this to stabilize your function. Okay. So, and it's going to keep you from getting worse. We look at the degree of spinal cord dysfunction. How bad is their gait? Can they do any kind of gait at all? Are they falling over a lot? Are they getting weak in their proximal muscles? Long track signs are the pathologic reflexes, and also their change in function. Are they dropping more stuff? Can they button buttons on their shirt? Things of that nature. Gait disturbance. The nice thing about this is when it does come to gait issues, there's a couple studies here that showed that even people with severe issues did get improvement in their gait. So this study showed 36 out of 37 got an improvement in their gait, and another study in 77 also showed 16 out of 17 got better improvement with their gait and walking. So it's not to say it got a lot better, but you can reasonably and reliably tell people that their walking may get better. The degree of dysfunction can be quantized, and this is a chart, and as you'll see, it talks about chopsticks and things of that nature, and that's because myelopathy is very prominent in the Japanese society, and a lot of our research came from that. And so these grading scales and things, we have modified now ones, but the original ones were with the use of chopsticks. So basically you can look at this and you can get, if they have less than 13 on this scale, and we add up each one of these numbers from each category, that kind of gives you the number of when you should consider to operate or not. And then looking at the radiographs, how bad their gait is, and then what's their motor strength like. Radiographically, normal AP canal for the spinal cord is 17 millimeters. And so that would be measured from the back of the vertebral body to the lamina. And most people walking around do have 17 millimeters. Relative stenosis is when you get down to 13 millimeters, and absolute stenosis is less than 10 millimeters. And the patient that I showed you, I think she was down to 8 millimeters, so she was very tight. And then the MRI, we've gone over that, shows you the myomalacia. And the bad thing about that is when you start seeing that cord signal, that myomalacia, i.e. the cord is dying, typically these people have increased amount of disability, and it gives you a poorer likelihood of recovery. So surgical indications, successful outcomes. Again, if you're a younger person, they do better. If you've had symptoms for less than a year, or if you've had stenosis at fewer segments, and if you have just one-sided symptoms, those all lend themselves to be a better outcome in terms of neurologic recovery and things of that nature. Things that you do want to advocate for surgery more so is if people are coming in and they're getting progressive symptoms, more numbness, more dropping, things like that. If they've had myelopathic symptoms for more than 6 months, you should consider intervention. And then there's also some numbers that we look at more for research, but compression ratios of 0.4, and really a total area for the cord less than 40 millimeters is very tight. And again, anybody who has really severe cord compression typically does not do well without surgery. So the goals of surgery for this are to really, the main goal, the number one most important thing is to decompress the spine. Take the pressure off the spine so it's no longer tight, it's no longer dying. The second thing is you want to stabilize the spinal column, and then if you can, restore the normal alignment. And these things all play together, but really the most crucial thing is just decompressing the spine. And really, there's a lot of different ways to go about it then. Would we go from the front to achieve these goals, go from the back to achieve these goals? How many segments are involved? And what is the alignment? So in terms of an anterior-based approach, this is kind of a picture of it here. if you go from the front side, that gives you an ability to, a lot of times you'll have a lot of degeneration here. And so going from the front would give you the ability to decompress the front and directly take that pressure off of the spinal cord. And you can treat up to 3 levels typically from the front. And when you're in the front, you can also put spacers where the discs were before, and that can help rebuild back in the normal lordosis of the cervical spine. And so you can fix the kyphosis that people have typically with degenerated necks. And the 2 things really from the front is either going to be just a ACDF, which is a anterior cervical discectomy infusion, versus doing a corpectomy. Corpectomy is when you take the bone out and put a big cage in, versus just taking the disc out and putting a small inner body device in. So those are your 2 options for the most part anteriorly. Posteriorly, there's a lot more options, and sometimes these things are done in tandem with one and then the other. The indication to go from the back side would be if you did have that congenital stenosis, because congenital stenosis means that you've got many levels in the cervical spine that are tight. So also, if you're dealing with more than 3 levels, or if you're up to 4, you should really be looking at going in the back of the spine to free it up. And especially if you have the ossification of the posterior longitudinal ligament that we looked at in that CT scan, that can be extraordinarily difficult to go to from the front. And so addressing that from the back is much better, and doing more of an indirect decompression. Surgery typically is going to be a laminectomy with or without a fusion, or a laminoplasty, which a laminoplasty is a type of surgery that does not fuse. So this is coming back to our patient here that we discussed in the beginning. Once again, her MRI. So this line here indicates just at the bottom of C2 is where I took off en bloc the spinous process and the lamina from the posterior part of the spine. So basically from here to here is what was taken off, and you can see that's this piece of bone and ligament here that came off of it, and then that's an intraoperative photo of the spinal cord after it's decompressed. So this is all the spinal cord here of the cervical spine. All right, and this is her final x-rays. So because she had the loss of her normal lordosis, I first went in the front and put these 2 spacers in the front of her spine and built that up, and then went posteriorly to do that 4-level decompression for her congenital stenosis and multi-level stenosis, followed by instrumentation. So that pretty much completes it, guys. The next thing is some questions, if you guys want to go over those now, or unless you have any questions or things you want to talk about first.
So in our world, this patient comes in and says, my neck is stiff. And then they may mention their hands are numb, and you look at their hands and looks like they have arthritis around the carpals and most likely carpal tunnel syndrome. And they're, how do we quickly, assess them, or what are, like with the low back, we commonly hear, see if they pee and poop right, and if they have any perianal numbness, and you're done. What's the quick way to just say, let's make sure we rule this out with every possible person that walks in our office? What do you do to just quickly in your head to do it, and then maybe do the eval?
So really it's the questions that you ask them. The history is going to give you so much. So you say, are you dropping objects? And typically people know if they're dropping more stuff more recently, or a lot of times our spouse is going to chime in and say something. So I ask about dropping, and then I say, how about buttoning shirts? Are you getting worse at buttoning shirts? And these people will be like, yeah, I struggle to get my shirt buttoned. And then you say, how about your writing? Are you writing okay? And they'll be like, no, that's gotten kind of bad in the last year or 2. So really, if somebody says, yeah, my writing's not great, but no, I'm doing great with buttons and I'm not dropping stuff, then probably not. If you get 1 or 2 of those questions, it's probably not it's less likely But if they start saying everything like, yeah, I'm clumsy with my hands, I'm dropping stuff, I can't button my shirt very well, I have numbness in my hands walking, I always say, hey, how is your walking? Do you feel like you're falling over more? How is walking on uneven ground? I mean, in about 10 seconds, I just rattle these questions off. And if they bite on more than two of them, I'm saying, we probably need to look at your need to look at your neck. And then I correlate that with the physical exam. I'm looking for hyperreflexia real quick. I do a reflexes on everybody. So if somebody's got really brisk patellar reflexes or a couple beats of clonus at the ankle, or even a positive Hoffman's, I'm going, no, we need to look at your neck here, you know. And then a lot of people, you're right, they come in and they're like, oh, my hands are kind of numb. But everybody seems like they've got something with their hands that are numb. I do a quick valence test on them. I put their wrists together. And if that starts making it more numb, just in the thumb and the index and the long finger, then you start looking more at carpal tunnel, or I do a Tenel's at the wrist and at the elbow. But it really, it's really keying in on those quick history questions and then correlating that to anything you can find on the exam of really hyperreflexia and things like that.
So now your suspicion is high. What are you doing for imaging right away then?
Oh, MRI. You got to do an MRI for it. X-rays are great, and I always get X-rays. X-rays are basically the orthopedist stethoscope. We use it for everything. We look at the alignment. We look at degeneration. Really, I'm going to look at the X-ray and increase or decrease my probability of having it. But with that said, you can get congenital stenosis, which you can measure on an X-ray of 13 millimeters. But if it has just a little bit of a degeneration that you can't pick up on the X-ray, that's what the MRI is going to find out. So, yeah, I always look at X-rays. That's just part of everything that I do. But to fully rule this out, you have to do an MRI.
Thank you.
Doctor?
Yeah.
It seems as though cervical myelopathy is kind of the end result of a natural progression of degenerative change of the cervical spine. How predictable is the development of true cervical myelopathy, which probably is kind of a misnomer anyway, because I think if we took an MRI, we could see MRI evidence of 98% of people that would suggest that they probably have myelopathy, whether or not they have clinical symptoms or signs. How predictable, my question is, how predictable is it that a patient is likely to develop serious myelopathic issues in the future? And if it is predictable, should we be a little more in tune to trying to make some corrective changes before we get myelomalacia and other irreversible problems?
No. So I look at a lot of MRIs all throughout the day, and that's a great question. But really it's you've got to correlate the physical exam and their history to the MRI. You can never just go in and say, oh, that MRI looks a little bit tight, we better do surgery. You have to correlate the images to the person. With that said, if you look at it and you see a cord signal and it looks tight, then yeah, that's something you need to take care of. But outside of a cord signal, I've got lots of people where I see and I say, you're not hyperreflexive. I can't find anything on exam. You're not telling me that you have any symptoms clinically. So I'm very comfortable just saying, hey, this is kind of tight on you. We'll see you back in 6 months to a year. These are the things that you need to be cognizant of and look for. And if you start developing issues of falling over or gait issues, come back and see me. We'll get the MRI and we'll go from there. But no, I would definitely correlate. It's the exam, the physical, all has to go into it. And there are plenty of people out there that have tight MRIs but are asymptomatic. So no, you don't have to do anything in those circumstances. Does that answer your question enough? Or you were also asking what's the likelihood of everybody getting this?
Yeah, kind of.
So it's, believe it or not, I get a little askew because I see it a lot as being, kind of the end of the road spine guy. But it's not incredibly common. It's actually fairly rare to have a real tight cervical stenosis like this. And I say that with caution because I think in more urban settings where people are more apt to get to go see their doctor and get this stuff flushed out, I think you find it a lot sooner. The cases that I'm seeing here are just people that have seems like they've neglected it for years, and it's getting to the point where they are getting some pretty severe symptoms by the time they come in, you know. So so I'm starting to think it's not as rare as I once thought it was.
Thank you.
So, like a lot of what you said when they present, when you put the upper extremity and the lower extremity together, the gait, dropping things, not be able to button, you know, you could throw that in with like an ALS or a lot of other neurological conditions. And being out in rural South Dakota, and I think with our limited number of neurologists around, if we were to refer those to a neurologist, it's months before they get them in, and it is sometimes you got to send all your notes, and they'll look at it. I mean, it's you just run into a brick wall. So that being said, if we see this, you're fine with us sending them to you, and then you can differentiate between, is it something you as an ortho, or should the neurologist look at them? And I'm hoping then you'd have a quicker inlet to the neurologist. Do you know what I'm trying to say?
Yeah, no, that's great. It really, I'm so in tuned, and that's just like you guys are with your practice, and you know what you do well, and you can get it in and out and take care of it. I'm the same way, and so I'm very in tune with picking this up and getting the MRI, following up, and I know exactly what you mean. It is incredibly hard to get into neurologists around here, and it is. Sometimes I make the call and try to get people in sooner, and oftentimes we can, but it is difficult. I know exactly what you're saying. So, no, I'm totally fine taking a look at all this stuff, getting the MRI, fleshing it out, following them up. I mean, that's my world. That's my thing. So I'm happy to take care of that stuff for you.
Now, how about on like a nerve conduction study and a EMG? If you're just going, boy, I think it's just basic carpal tunnel, will that show any findings if the cord compression is that severe, or it will not show up at that level?
I never depend on EMGs or nerve conduction studies when it comes to spine stuff. They're very, very hit or miss. You really have to be in tune to doing paraspinal muscles and things like that. I haven't found that to be very reproducible. And even if you do have a good neurophysiologic study, the sensitivity and the specificity of that is extraordinarily lacking. So really the MRI is the test to do for it. EMGs and that stuff are good for peripheral nerve issues and not as reliable for spinal cord stuff.
Good, thank you.
Other questions for Dr. Geisinger? Now's your chance.
Just on somewhat of a different subject, but are you doing cervical disc replacements then, if indicated, on not necessarily on this problem, but on a...
Yeah, I should do a talk on cervical disc. That's a hot topic on a lot of people's minds. So basically, yes, I do them, but the thing is, I'm very, very conservative when it comes to this. I think even in everybody's industry, you got to remember that everything with implants and things are incredibly driven by industry, and there's going to be money behind those things funding them. And a lot of these companies that say, hey, this disc replacement is great, let's publish this article and get it out there how everybody thinks this thing is so wonderful. A lot of those studies are all financed by the companies who made it. And then in the fine print, they have the right to refuse publication. So if they find something they don't like, those companies say, oh, we're just not going to publish that paper, and it goes away. Nobody ever knows about it then. So discs have been out for about 10 to 15 years. There is 12-year follow-up for them about now, and they do have good results. But with that said, I'm still very cautious about it. If you have the exact perfect indication, being a young person that you want to keep motion, and they don't have any other substantial adjacent segment disease and things of that nature, then yeah, it can be a really good procedure for them. And I do them, and I think it's fine. But I give the patient both options, and I tell them the pros and cons of each one. To be honest, personally, if it was me, I would probably at this point still go with the ACDF. If it's just a 1 level, they do very well. The motion that they lose is very minimal, and it's just so tried and true and historic, and it's hard to go away from that. But I'm a student of the literature, and as of right now, it is looking like it's okay to do for the correct indication. So yeah, I do them as well.
All right. Well, Doctor, you want to just go through those? You want to go through the questions quickly?
Yeah, let's do that.
Let's do that.
So what is cervical myelopathy? A, dysfunction of the spinal cord due to severe tightness on the cervical spinal cord. B, pain that goes down the arm. C, pain down the leg. Or D, cancer of the cervical vertebra.
Yeah. So these will be the questions that you'll get on when you get the link for the test. So he's just going to go through and just let you know what the questions are going to be. So if you want to just go ahead and go through them.
What are the possible symptoms of cervical myelopathy? And A, clumsiness in the hands, dropping objects. C is difficult walking on uneven ground, worsening penmanship, problems buttoning your shirt. Or F, all of the above. What's the natural history of cervical myelopathy? Stepwise decline in function, meaning an abrupt decrease in function followed by a period of time with stable function, followed by another abrupt decrease in function. That's all in A. B, it usually gets better without any treatment. C, it usually does not get worse, it just stays the same. And D, there is no known natural history of cervical myelopathy. 4, is there a role for non-operative treatment for cervical myelopathy? Which is A, yes, mild cases of cord dysfunction can be monitored closely with regular follow-up to assess for subjective and objective signs of cord function. Or B, no, all cases of cervical myelopathy need urgent surgery. 5, what is the primary goal of surgery for cervical myelopathy? And the answer foils here are A, to take pressure off the spinal cord, B, to fuse the spine, C, to restore the natural spine alignment, or D, none of the above. And 6, how do patients do after surgery? Typically, patients get worse. Typically, patients get complete recovery. Or C, oftentimes patients do get partial resolution of their symptoms, especially gait improvement. But patients are told that surgery is to arrest the symptoms they currently have and hopefully get some improvement. So I think those should all be pretty self-explanatory. One of my best teachers always said, just always pick the longest one. So.
Well, and you're the type of professor we liked in college. You told us what the questions were. We just had to make sure we knew the answers, right?
Yeah. Yep.
Yeah.
That's comforting to know that that's how you got through school. That you.
That's right.
Yeah.
Best advice I ever got. So, so that's my name. That's you guys can write that number down. If you want me to see anything, you can just call my executive, Serena, and she can get you an appointment. I have spots that I keep open just for chiropractic referrals, so I can pretty much get anybody in within a day or so.
Good. And once again, Doc, obviously Dr. Wingate comes to Huron where I'm at, and you're Sioux Falls, and where else are your outreaches then?
Brookings is my other spot I'm at right now.
Okay, sounds good. Sounds good. Very good, Jeff. I would try to line up that disc replacement or really anything else. I think he's very good, so it'd be good to keep learning from him. That would be awesome.
All right. Well, thanks, Dr. Geisinger, for taking the time to educate us, and then everybody else. Thanks for being on the session, and we'll look forward to doing more in the future.
You're going to make this. slides available to everybody, Jeff?
Yes, yep. And when I send out the test, we'll try and have the slide deck attached to it. All right. Well, thanks everybody.
Great. Thank you.
Thanks, guys.
Have a
Thank
good
you so much, guys.
Yep. See you. Thanks.
Bye.